technique, troops, notice you go for anywhere from 500 to 1,000,000 counts, and then whatever time it takes to do that for the anterior or posterior chest, you just use that for all your other spot films. Make sense? And because that, see, this says this will allow you the comparison of film density and all the images obtained. Okay, so you have more consistent information density. Okay, the SPECT imaging, normally, like I said, you're going to do it on areas where you have superimposition. L-spine is probably the worst, but some people do. I don't know why people do it on the knees. Have you guys done any SPECT imaging on knees for anything? How about L-spine?
Yeah, I've seen an L-spine SPECT.
Okay.
L-spine hip.
Keep in mind on this though that you're going to do a 360-degree rotation with 64 projections. You're probably going to be using about 20 to 25 seconds per projection. Okay.
Is that pretty much all SPECT, 64 projections, 20-25 seconds?
Well, it depends on the number of counts. Because if you have less counts, 30 to 40, yeah.
64 is the minimum.
Yeah, 64 is standard for all SPECT images. Okay, if you have a dual head, then you're taking 32 with each one. So it's a lot faster. But otherwise, if you have a single head, you're going to be there for at least, 30, 40 minutes. But if you're doing gallium, indium, anything where you're either injecting a small quantity of radioactive material, or it's been a long time since the injection and the scan, you're going to be taking a longer time. But usually anywhere from 20 to 40 seconds is considered probably fairly standard. Okay. When you guys did your SPECT, what time intervals were you guys using up in Fresno?
I don't know. It's one of those things where you see it and then you walk away to go to something else and then it's done.
Okay.
It happens a lot.
But just keep that in mind. Like I said, when you're doing a gallium scan or an indium scan, whole SPECT, it's going to take longer because you want to remember the statistics is what we're worried about. And that's why we use a 64 by 64 matrix most of the time when we're doing SPECT images, because of the statistics. Okay, so this is just a typical whole body scan here. One of the things I hope I see on all of your images, okay, I don't like it when people have their heads turned to the side. I like to see the arms both in the same position, ideally in the anatomical position.
Nice injections.
Huh? Yeah, well, I'm going to show you a problem with this later on because, sometimes if you have a really bad extravasation, you'll actually see lymph nodes picking that stuff up. You'll see hot lymph nodes. Yeah, I've got a picture I'll show you here a little bit later. But the thing is, you want to make sure the patient is completely symmetrical. Everything is the same distance from the detector so that it doesn't appear hot or cold. It takes a little bit of extra time, but it's going to give you a much more quality image. And the thing down here, I like to see people turn the feet in. Tape them.
Yeah.
Get one of those 45-degree oblique sponges, rest their feet on it, tape them together. That gives you a very beautiful separation of the tibia and fibula. It just makes you have that much higher quality. Because, as I told you, when people start evaluating who they're going to promote, they look at people who take that extra time. Okay? And the doctors who have to look at this, because on this one here, you've got one hand in one position, the other hand in another position, so you're not really getting a good comparison of the radius and the element. Okay? So that would be good. I like to see the head rather than being cocked like that. I like to see it nice and straight so you have a nice... If you were to follow the, from the glabella to the mentum of the chin, all the way to...
Excuse me.
Bless you.
Thank you.
Okay. So these are the planar views here. Normally on pediatric cases, this works the best because it's quicker. Kids move around a lot, and so you have to repeat them. I'm sad to say they didn't do an anterior or posterior view of the skull. But as I said, normally you do an anterior, both laterals. Do a chest, and probably both, and maybe half a chest here, half a chest here. So you might have about 10 pictures altogether.
But why can't we do AP? I mean, you know, we put 2 sponge here
Yeah.
and keep the head and then tape it, we can do AP.
Well, unfortunately, there's some people who would rather get it done quickly rather than doing it correctly. I know a lot of, having worked at Children's Hospital, we found all sorts of things that were surprises. A lot of times child abuse, for example, shows up on,
Non-accidental trauma.
yeah, non-accidental trauma.
I work at Children's, so I know all about bone surveys for non-accidental trauma.
Yeah.
Not fun stuff.
That's what actually got me in law enforcement. So, and I worked juvenile investigation for 2 years before I got to the point where I was going to kill people. Okay, anyway, so here's our situation. This is a very common problem. You really can't see what's going on here in the lumbar sacral spine area. So here we have the axillary views. Okay, here we have the sagittal views. Then here we have the coronal views. So you can see that there is actually pathology there. I don't know if you guys can see that down there. So, I mean, most places, I know that Cedars-Sinai routinely just does SPECT on everybody, so it doesn't matter. Okay. This is kind of an important thing as to what to expect. So, the SI joints, so notice we have SI joints down here that are hot. Anterior iliac crest, I'll see that area up here.
Is that just because it's closer to the...
Is that the,
It just seems that there's more stuff going on up there. But remember that when you're always, positioning patients, you're always looking for symmetry. So this side should look like this side, right?
Yeah.
Okay. The sternum usually is hot a little bit. Okay, in this case, well, here we have a child though, right? Or somebody who's under the age of 18 at least, because we have a lot of growth plates that haven't closed. But see how bad it looks down here? That's especially with kids. You want to make sure that they have their feet turned in. Nasopharyngeal area is usually hot. Shoulder joints are hot. Spine, and not always hot. Okay, and then children, okay, epiphyseal plates we talked about. Costochondral junction. So here we see that the costochondral junction of the ribs, hot. Now, one thing that's kind of worse in here is we see that there's not much activity in the kidneys, is there? But notice it says activity in the kidneys that's less than the bone activity. Okay? And then sometimes in female patients we'll see the breasts, and you may even see it with breast cancer, because remember that this stuff also localizes in infarcted tissue. Okay? So, what causes abnormal findings? These are some of the good old things that we have here. Obviously, cancer or bone diseases. Those would be things like Paget's disease, osteoarthritis, gouty arthritis, metastasis. So all of these you've probably seen as part of your histories at some point or another, correct?
Yes.
Okay. So what do we got going on here, folks?
Stroke.
Huh?
No, that's not like a blood.
Okay. Mr. Singh, what are you going to do with this patient?
Spectrum. Tumors on his head?
ER.
Huh? Okay, Ashley, is that in the skull or is it in the brain?
Looks like it's in the brain from the other image.
Okay, well,
Tell the radiologist to read it stat.
if we didn't have a CT scan there, you'd probably say, oh, he's got metastasis to the calvarium, right, to the skull. Okay, remember I told you one of the things we used to use these bone scanning agents for was to evaluate stroke patients and heart patients. So if you've had a recent stroke or heart attack, part of the repair process involves the laying down of calcium phosphate as scar tissue. So this is actually a stroke that's healing. Okay? So that isn't even in the bone. Okay, it looks like it's in the bone, but it's not in the bone. So this is a stroke that's healing. Now the bad news is about 10% of the strokes that are healing are due to metastasis to the brain. So it's something to be aware of. And if you're using iodinated contrast on patients that have metastasis, then you're also at risk now of them having a seizure. So this is kind of an important thing if you're doing a CT scan, especially with contrast. Okay? Here's another one here. These are horrible pictures. I know that you guys are going to do a lot better. But these images here were probably done with analog with film. So here you have a patient. We've got metastasis in the bone, at least a couple that I can see, but whoever did this should be fired. But the thing here, okay, again, this is a lesion in the liver that a lot of times these things, as they're healing, they become calcified. So they'll pick up the bone scanning agent. This is actually a soft tissue tumor from from liver mets.
So when you say it becomes calcified, why would it pick up the magnesium?
Well, remember that this stuff, the calcium phosphate is what your body lays down to start forming the scar. Okay, so anytime you have an injury, one of the first things that gets laid down is calcium phosphate to build kind of a strong layer so that the other tissue, the other fibrous tissue can grow over it. And basically there's not going to be any blood there anymore because calcium phosphate is just going to make like a concrete tomb for it.
Would the sodium chloride also go there?
Which one?
The sodium chloride? Or fluorine or something?
Probably not. This would probably not, unless there was, this probably wouldn't pick it up.
So only the magnesium and the...
Yeah, the calcium phosphate would pick it up. Because remember, if it's a calcium analog or if it's a PO4 phosphate analog, it would pick it up. I don't think sodium chloride would go there. Okay. FDG would probably go there. 18 FDG would go there, but I don't think that, the other stuff would. So this is what they call extra osseous activity when that happens. Okay? This is another interesting one here too. People that have lung cancer, usually they don't live long enough for the cancer to metastasize to the bone. But this is a lung scan, or this is a lung cancer patient. Here's the cancer here. Okay, in the right mid-highland area in the bronchus. But if you notice lung cancer patients, they get this like accumulation of MDP in the periosteal region. So it surrounds the bone. They call it osteoarthropathy. It's not metastasis. There's no metastasis there, but for some reason, you notice it goes all the way down to the fib area.
What's it called? Osteo what?
Osteo what?
It's called osteoarthropathy. Okay. I've got another picture up here. Yeah. This is a case here also. This patient, this is the initial scan over here. Patient has lung cancer. Lung cancer doesn't usually go directly to the bone. And like I said, they don't usually live long enough for it to spread to the bone. But you notice again in the femurs, femurs and tibias, they have this increase in periosteal activity. Nothing anywhere else, only in the extremities. They have radiation. Now, this is a recent radiation. Notice this area up here? Okay. So they have a tumor, they have lung cancer in the apical area, but notice you don't see as much as that osteoarthropathy anymore. Okay, so following treatment. Okay. I like this picture here. So it is significant, you guys. You know, a lot of times we take it for granted, the extremities, don't we? Yeah. Oh man, you know, we want to look at the spine, we want to look at the ribs, the shoulders, but we don't take a look at the whole picture here.
So patients with lung cancer or patients post-treatment of lung cancer?
So patients with lung cancer. Okay, this is the same patient, but this one here, I put the X-ray in on it. Okay. Okay, so bronchogenic lung cancers, small cell cancers, all of those. Okay. Now, going back to our good old endocrine system, what do you guys notice about this one is more obvious here on this side than over here. But what do you notice about both of these patients? What would hyperparathyroidism do?
Increases calcium,
Decreases the,
lowers the phosphate levels
calcium.
in the blood.
So it's an increase in calcium, decrease in phosphorus?
Okay, so it takes calcium off of the bone and puts it into the blood, right? And then changes the phosphorus levels.
Yes.
Okay, so you notice here, do you see very much bone?
Mm-mm,
No, do you see lung?
not really.
On the one up, yeah, yeah, you do.
Oh, I was looking at that picture.
Yeah, this is one patient here, this is another patient over here. This one is more advanced hyperparathyroidism, but notice that the bones are demineralized
Yeah.
and there's a lot of soft tissue uptake, especially in the lungs and the stomach.
Why would it take it up in the lungs and stomach?
It's actually just in circulation. Okay, the calcium is just in circulation around there. Okay. This is not a very good scan. Osteoporosis, though. Okay, remember it's a very, very common problem these days. Okay, now usually you're going to see compression fractures. That's very, very common. Okay, obviously you're going to want to take X-rays of those. Okay, make sure that it's compression fracture. It isn't metastasis from something else. But notice that the bones don't pick up the, the mineral stuff is there, but the protein is gone. And the protein helps provide strength for it. So this is one type of a problem that you see is compression fractures. And this is what they call a sacral fracture. Again, osteoporosis. Okay. Primary bone cancers. Not good, huh? This is your state-of-the-art, or this is your gold standard here. So you can see this is an osteosarcoma. This is one of the more aggressive tumors. Unfortunately, it hits kids usually between the ages of 5 and 15. It's a real common tumor in that age group. So it started here in the distal femur. There's a metastatic site up here. This type of cancer spreads via the blood. And so remember, this is where the nutrient artery comes in. So usually I'm really surprised that it started down here. But normally when you have metastasis or anything like that, it normally spreads to the femoral neck and to the humeral head, because that's where the nutrient artery comes in, and the cancer cells get trapped in that first bed of capillaries and start growing. And like one of the things we were talking about, making sure that the child is properly positioned. I would be very concerned about this, since I can't see this area over here. It would not be uncommon to see it up here. Normally osteosarcoma goes to the lungs, and that's usually it. They usually slice and dice the kid. This kid probably lost, they had to do a hemipelvectomy, so they cut off half of the pelvis and took it.
Wow.
Now, if you didn't know this patient's history, you'd say, oh my God, this person is done, right?
Mm-hmm.
But what is osteomalacia? Okay, softening of the bone. What causes it?
The bone not converting to the strong, it's like the cartilage still. It makes it, I don't know, it's been a minute, but I've been hurt.
This
It's like it overproduces something, and then like the bones doesn't, I don't know, it's not proper.
Well, here's the thing, okay? It has to do with the bones not having enough minerals in the diet. So either you're not taking enough calcium in, or you're not getting any sunlight to make vitamin D, or you have renal problems, because remember the kidneys actually manufacture vitamin D and send it up to the skin to be activated by sunlight. You need that for calcium to be absorbed by the intestines. Okay? So you could also have secondary parathyroidism. Yeah, renal failure. So, but anyway, I mean, that's why history is important. If you thought this patient had cancer, man, they're done. Say, don't just go home. This is osteomalacia. This is a treatable disease, hopefully. Okay, this is a metabolic bone disease. Now, they still don't understand this Paget's disease, or osteogenesis imperfecta, because basically what's happening, the bone is destroying itself and repairing itself at the same time. They don't know why. The bad thing about it is that you often see a lot of bone cancers that will develop in people that have Paget's disease. Okay? But notice you got sporadic areas here. This guy looks like he only has it here in the pelvic area, and this guy has it in the skull and pelvis and legs and things like that. Okay, and then again, here's the pictures that we looked at before. 3-phase bone scans for trauma. So remember, they're not just for osteomyelitis. If you guys worked at a sports medicine imaging center, man, you'd be doing these things night and day. You get all these runners coming in, and football players, and things like that. So, okay. This is one we were talking about here before, this leg calf Perthes disease. Now, this is a leap collimeter up here. Okay, the kid has the problem on the left side. Okay. So they're taking half of the pelvis at a time. These are pinhole pictures here. Here you see the epiphyseal plate here. Here you see a cold spot. Down here you see a cold spot in the femoral neck area. Kids that are taking steroids, kids that have a hip fracture, it's very common that you develop avascular necrosis because you cut off the blood vessels. Okay? So this is why it's so important to, this would be a good exam to do a 3-phase bone scan. Take a picture of the blood flow to those areas there. Remember the other one we talked about is the tibial tuberosity. Some people call it shin splints. But the tibial tuberosity gets pulled off by the tendon because the kid's growing too fast. I think that's what they said causes it. Okay, let's see what we got here. So the 3-phase bone scan. You've all done this. We have a 4th phase bone scan. Did you know that? Sometimes you have the patient come back 24 hours later. Okay? That's called a 4th phase. So, dynamic for about a minute. Now, what do you guys normally do for your 3-phase? Do you do 3 seconds per frame or 2 seconds per frame? I wanted to talk about that because this is what we call frame mode. Frame mode is either for static or dynamic acquisitions. Okay? And typically for something like this, you're probably using either a 64 by 64 matrix, maybe 128 by 128. And so again, the history is very important. Okay? Patient has diabetic ulcers. Okay? So now you know you're probably looking for osteomyelitis versus cellulitis. So it's hot on the flow. Okay? That's the perfusion. One of the things I really like to see when people do these is right and left markers. and the radionuclide that was used. You know, the time per frame. Do you guys like that kind of stuff? Or would you rather just guess at it like we are right now? Okay. So make sure you include all that information, annotate them on there. Okay? What they call the blood pool or immediate phase. Now, how soon after you do the flow do you guys do the delayed pick or the immediate? Ashley, what do you guys do?
Immediately.
So like 1 minute after?
Maybe by the time you're done with the first picture, it'll be about 3 or 4 minutes after.
Okay. Some people just automatically have it chain into it. So you do the like 1 minute flow, and then right after that it immediately starts acquiring the static immediate film. Then you schedule them to come back 2 hours later. Okay. So this is a knee here. And if we go back, you remember that this area was hot on the flow, it's hot on the blood pool or the immediate picture. Okay, and they call that hyperemia. Okay, that's what they're looking for, is hyperemia on the second page. Because it does indicate that there's an inflammatory process going on. Doesn't always necessarily mean it's osteomyelitis. Okay, then the third phase, the delayed picture. These are just some of the applications. You know, we just saw that you could do a 3-phase bone scan for bone mets, osteomyelitis, and stress fractures. Let me just get to the delayed picture here. Somehow my timing, I lost it. Okay, this is probably the most common area that we do osteomyelitis. The foot. Okay, plantar pictures of the foot. Okay. Here's the immediate. Now, I don't know why they took so many immediates, but then here's the delay. So, in your opinion, with a hot flow, hot immediate, and hot delay, what's the diagnosis?
Wait, osteomyelitis?
Okay, osteomyelitis. Okay, that's one of the key things that will be expected to know for your board exams. They'll give you a picture with all 3 images, and they'll tell you, okay, what's the possible diagnosis? Okay, what if it was hot on the first tube, but cold or normal on the delayed?
Probably just infection, just soft tissue infection.
Yeah. Okay, now the 2 things that I sent you guys, one of them is a real interesting thing that one of the doctors did on imaging bone tumors. So take a look at that, but hey, the bone sarcoma, now this is a primary tumor. Still, they love MRI, but it's very time consuming to do an MRI scan. I think you're going to start seeing more sodium fluoride PET scans with this. Okay. Notice as the bone scan, it's not used for the initial diagnosis. It says MRI provides more exact information regarding tumor extent. I think you guys saw that in the comparison of F18 and MDP. Okay. Bone scan is not the primary tool for that type of diagnosis. Okay. Bone scans are used for staging and restaging in bone sarcomas. So if we know what was there, we can get an idea if it's getting better or getting worse. Okay, it says 50% of patients with Ewing sarcoma or osteosarcoma develop osseous metastasis within 2 years, if they live that long. The osteosarcoma is really bad. What do you notice about this one, guys?
That's the inflammation.
Actually, this is a Ewing's large cell tumor.
Causes it to get so big. It's just
The cells get huge. They block the lymph node, or they block the lymph flow. They've totally destroyed the bone. And then, as Ashley was saying, when you have a fat person, you don't get as good an image. There's a lot of scatter and attenuation as a result of all that fluid and junk in there. So, this is another osteosarcoma patient here. Very important to identify where you injected, because the especially with osteosarcomas, they could develop anywhere. Most of the time they're going to be in the lower legs, sometimes in the ribs, but, you know. Okay. The metastasis, okay, you guys have all done this. As I said, the main cancers that you look for are prostate, breast, and lung cancers. But even though you've seen, the lung cancer doesn't necessarily metastasize to the bone, but it does cause a periosteal reaction for some reason. Okay. This is kind of an interesting statistic here. 80% of patients with cancer and bone pain have metastasis. So that's a bad combination. If they know they have cancer, they've got bone pain. 30 to 50% don't have any pain. So they often wait. Says metastasis is definitely more than one area of osteoblastic activity. But again, what people tend to overlook are the lytic lesions. So if you see areas where there's a decrease in bone activity, that's just as bad as an increase. Okay. What does that look like to you guys?
Metastasis.
Okay, you remember the term super scan. Okay, what is a super scan?
Where all the tracer goes to metastasis and there's no kidney or soft tissue.
Right. So this is not a good sign when all of your radionuclide goes to the bone and there's no excretion or very minimal excretion. Okay, what would you call this guy?
I'll say.
Do you have any history of it? I would say osteosarcoma.
Osteosarcoma? Why? Where do you see abnormalities, guys?
No, I would say Max.
Shoulders, ribs, knees.
Neck?
Could be like a prostate or breast and it just metastasized.
Just be arthritis.
Well, here's, okay, yeah, this is metastasis because you got some in the spine and in the ribs. But some of this up here is osteoarthritis in the neck.
How can you tell?
That's just it. You can't. You need to get x-rays. Okay? Sometimes you have, arthritis will create hot spots, just as the cancer does. And often, down here we have an injection site that the patient is resting up against their hip. Remember this, what do we call this defect here when we don't see the whole patient?
Truncation.
A truncation artifact. Very good. Okay.
So when the cancer metastasizes to the bone, it's not called osteosarcoma?
No.
Even though it's
Now, an osteosarcoma is where it's a primary tumor of the bone itself. It's not something that metastasizes. It can go to other sites, but usually it's not. What was I worried about with this guy? We've got a couple of areas. In the arm, yep, spine. Yeah, the kidney, one of the things that you need to keep in mind, got a couple, one on the hip here. Sometimes this can be urine contamination. Here's the injection site. I don't think this stuff up here is, but keep in mind that sometimes, especially in the lower extremities, you can have urine contamination.
That's
Um,
osteosarcoma.
What's that?
Is that urine too?
No, because he's got a lesion up here. He's got stuff in the spine. Probably stuff there. I'm trying to find. Let me just. Why don't you guys take a stretch for a second here?